for decades, the standard approach to, a lot of women's health issues, especially around aging and menopause,
Yeah.
it's just felt incredibly temporary.
Oh, absolutely.
It's kind of like the medical equivalent of putting a bucket under a leaky roof, right? You're handed a moisturizer or like a lubricant, and you're essentially just told to manage the discomfort.
Yeah, it's pure symptom management. I mean, the medical field has historically focused on just treating a dry surface, completely ignoring the massive structural collapse that's actually happening underneath that surface.
Right. But we are throwing away the Band-Aids today. We're looking at a fundamental shift in how the medical world treats the female body. We're moving past those temporary fixes and diving straight into actual cellular tissue regeneration.
Which is such an exciting space right now.
It really is. Specifically, we're exploring how combining two very different therapies, a localized topical estriol cream and this non-hormonal treatment called polynucleotides, can essentially instruct the body's submucosal microvascular networks to just, rebuild themselves from scratch.
Yeah, we're talking about literally reprogramming degraded aging tissue to function as if it were years younger.
Exactly. And to understand how this is even possible, we're pulling from some really fascinating research for this deep dive. We've got a real-world clinical study published in Obstetrics and Gynecology Reports. We're looking at some grounded clinical protocols from the Women's Health Clinic, and we have these really dense pharmacological reviews on tissue repair.
Yeah, those pharmacological reviews are key to really getting the mechanism here.
For sure. So whether you are, personally navigating menopause, or maybe you're looking into non-hormonal options after a cancer diagnosis, or you're just insanely curious about the cutting edge of cellular healing, this deep dive is for you.
It's a game changer.
But before we get into how to rebuild the tissue, we really need to understand the collapse first. Let's talk about GSM, genital urinary syndrome of menopause, and vaginal atrophy. What is the actual biological trigger here?
Well, the trigger is a catastrophic drop in hormones. Like, during a normal premenopausal menstrual cycle, a woman's estradiol levels can peak around 800 picograms per milliliter.
Okay.
But during and after menopause, that level just plummets to below 30.
Wow. Going from 800 down to 30, that isn't a transition. That is a physiological shock to the system.
Oh, totally.
And the tissue in the female genital tract is incredibly estrogen dependent.
Highly dependent, yeah.
Yeah.
When you withdraw that estrogen, this rapid domino effect begins. First, the natural anatomical rugae, and those are the healthy folds of the vaginal wall that actually allow for expansion and stretch, they just begin to flatten out entirely.
Right.
The mucosal layer thins out. And then in the deeper layers, something called the lamina propria, you see the severe depletion of collagen and elastin fibers.
Which means the structural integrity is just vanishing, like the scaffolding is dissolving.
The scaffolding dissolves, and the whole chemical ecosystem collapses alongside it. The epithelial cells lining the vagina actually lose their internal glycogen.
And glycogen is basically the food source for the beneficial bacteria, right?
Well, exactly, the lactobacilli. So without that food, the lactobacilli literally starve and die off.
Right. And since those bacteria are what produce lactic acid, their absence means the vaginal pH just shoots up.
Yeah, drastically.
It goes from a healthy, protective, acidic state of, maybe 4.0, up to a much more alkaline state, which just rolls out the red carpet for irritation, inflammation, and chronic infections.
It creates an incredibly hostile environment, yeah.
Okay, let's unpack this a bit, because I think people hear atrophy and they just picture like a dry surface.
Right, they think it just needs lotion.
Exactly. But based on this physiology, it's more like a landscape where the underground rivers have completely dried up. And when the water table drops that drastically, the topsoil cracks, it turns to dust, and it just loses all its structural integrity.
I love that analogy.
And in this anatomical case, those underground rivers are the submucosal microvascular networks, the tiny blood vessels that actually feed the tissue.
That is a brilliant way to visualize it, because the loss of that microvascular density, that's actually the most painful part of this condition.
Really?
Yeah. The tissue literally becomes starved of blood and oxygen. We call this an ischemic state. When those microscopic rivers dry up, the tissue becomes so friable and paper thin that it develops petechiae.
And petechiae being those tiny, painful microhemorrhages, right?
Yes. The structural breakdown is so severe that even the lightest contact causes the tissue to tear and bleed. It causes intense chronic pain.
So if the foundational structure is entirely gone, if the underground rivers are dry and the collagen scaffolding has completely collapsed, how can a simple topical hormone cream fix it? I mean, if I pour water on cracked topsoil, the water just evaporates or runs off. It doesn't rebuild the dirt.
Right, and that brings us to what localized estriol actually does at a cellular level, because replacing estrogen directly at the source,
Yeah.
that is the traditional gold standard. But estriol isn't just watering the soil.
Okay, what is it doing then?
It acts as a highly specific chemical messenger. It is literally sending an instruction manual to the local cells, telling them to dig new rivers.
Wait, estriol is one of the weaker hormones, though, isn't it? Like, compared to estradiol.
It is, yeah. It's a much weaker natural metabolite, but when you apply it topically, it binds directly to the estrogen receptors in the female genital tract. And the moment it binds, it acts incredibly fast.
How fast are we talking?
Within an hour in some cases, estriol upregulates something called VEGF.
Vascular endothelial growth factor.
Yes, VEGF is the body's master regulator for angiogenesis, which is the creation of brand new blood vessels.
Wow.
So by applying the estriol, you aren't just moisturizing, you are explicitly instructing the tissue's cellular machinery to rebuild its own vascular network from the ground up.
It's basically triggering an architectural rebuild.
Exactly. And it defends the existing architecture at the same time. Estriol actually inhibits MMP9, and MMP9 belongs to this family of enzymes called matrix metalloproteinases.
Right, I always picture MMPs as the body's microscopic wrecking balls. They just roam around degrading the extracellular matrix.
Yeah, that's a good way to look at it. And you need a certain amount of them for normal tissue turnover, like clearing out old cells.
Hmm.
But in an atrophic, estrogen-deprived state, those wrecking balls just run rampant.
They just smash whatever collagen's left.
Exactly. So estriol stops the wrecking ball, and simultaneously it stimulates the fibroblasts, which we can think of as the cellular construction workers, to produce new type I and type 3 collagen.
Okay.
So you get new blood vessels, a halt on tissue destruction, and new structural proteins.
See, if estriol is this remarkably effective at instructing the body to rebuild its own vascular network and collagen, I have to ask why we're even looking for other options. Like, is there a physical limit to what hormones can do if the cellular machinery is just too far gone? Or is this purely about the cancer risks for some women?
It's really a complex combination of both. For a significant population of women, particularly breast cancer survivors or those with non-hormonal gynecological malignancies, any form of estrogen therapy, even localized estriol, can be an absolute medical contraindication.
Right. Their oncologists will simply not allow it.
They won't, leaving them effectively stranded with severe medically induced atrophy from their cancer treatments.
Stranded and in a lot of pain.
Exactly. But even for women who are perfectly safe to take hormones, there is still a biological limit, because if the tissue has been starved of estrogen for a decade, the local estrogen receptors might be profoundly depleted.
Oh, I see.
So the cream is there, but the receptors aren't available to catch the signal. The tissue just struggles to respond. Science had to find a non-hormonal way to bypass the estrogen receptor entirely, but still trigger that exact same cellular repair, specifically the VEGF and the collagen production.
Which brings us to the clinical protocols from the Women's Health Clinic and this non-hormonal treatment called polynucleotides, or PNs. And I have to admit, looking at the sources, I did a double take on what this actually is.
It's wild.
It really is. We are talking about highly purified DNA fragments extracted from the gonads of male salmon trout.
It sounds like pure science fiction.
It really does.
But the biochemistry behind it is just incredibly elegant. These are highly purified DNA fragments ranging from about 50 to 2,000 base pairs.
But wait, if a clinician injects foreign fish DNA into highly sensitive, already degraded human tissue, shouldn't the patient's immune system completely freak out? Like, why doesn't this trigger massive inflammation and rejection?
Right, you'd think so. But it's because of how it's processed. The extraction involves intense thermal sterilization that strips away all the immunogenic proteins.
Ah, okay.
And proteins are what trigger your immune system to attack. By removing them, you are left with purely the structural blueprint of DNA.
Yeah.
It becomes virtually invisible to the immune system.
Okay, here's where it gets really interesting. Once it's in the tissue, it utilizes something called the salvage pathway. This is easily my favorite concept in this entire deep dive.
It's so efficient.
It is. Instead of a human cell having to build DNA components from scratch to repair itself, which takes a massive amount of cellular energy-native enzymes in the vaginal tissue, gradually break down these injected salmon polynucleotides into free nucleotides.
Yeah, and those free nucleotides are instantly snatched up by the local fibroblasts. The human cells use those free blocks to repair their own cellular DNA and rapidly divide.
It is exactly like delivering a truckload of pre-cut lumber and a stack of blueprints directly to a construction site. You aren't forcing the exhausted construction workers to hike into the forest, chop down their own trees, and mill the wood themselves. You're just handing them the exact materials they need to start building immediately.
Handing them the materials and simultaneously telling them to calm down, because polynucleotides do a second, equally vital thing.
Okay, what's that?
The adenosine in these DNA fragments binds directly to A2A receptors on the surface of those dermal fibroblasts.
Oh, and I know A2A receptors are heavily involved in regulating inflammation.
Yeah, they act as a massive anti-inflammatory switch. When the polynucleotide hits that A2A receptor, it aggressively downregulates pro-inflammatory cytokines.
And cytokines are basically those chemical alarm bells that cause inflammation, right?
Exactly. One of the main ones it quiets down is IL-6. So you're providing the pre-cut lumber for new tissue while simultaneously putting out the inflammatory fire that was degrading the old tissue.
How does this actually feel physically in the body, though? When a clinician injects these PNs, is it just like a thin liquid that absorbs and disappears, or does it provide some immediate structural support to this paper-thin tissue?
Oh, the physical presence of the treatment is actually a crucial clinical advantage here. Polynucleotides are incredibly hydrophilic. They just love water.
Okay.
So the moment they're injected into the tissue, they form this 3D viscoelastic gel.
Like a microscopic sponge.
A very dense sponge. They immediately bind to surrounding water molecules, which provides instant mechanical hydration. It physically plumps the mucosa, giving it immediate cushioning and structural support.
That makes a lot of sense, the instant relief of hydration.
Yeah.
But the real magic is the long-term signaling, which brings us to an incredible point of convergence between our two therapies. We established earlier that estriol upregulates VEGF to grow new blood vessels.
Right.
Well, polynucleotides, completely independent of estrogen, do the exact same thing.
They do. Through that A2A receptor activation, the polynucleotides stimulate robust VEGF secretion.
Wow.
When researchers look at this tissue under a microscope, they use a special dye called CD31 staining. And CD31 only sticks to blood vessels. So under the microscope, tissue treated with PNs literally lights up. It shows a dramatic, dense increase in new microvessels.
Which is really the core of our deep dive today. Whether you are using the hormonal key estriol or the non-hormonal key polynucleotides, you are unlocking the exact same biological door, vascular endothelial growth factor. And you are turning the underground rivers back on.
Which is why the most advanced clinical protocols are now focusing on combining the two. I mean, think about the synergy there.
Yeah, it sounds powerful.
If you use polynucleotide therapy to physically hydrate the tissue, provide the raw DNA building blocks, and activate the anti-inflammatory A2A receptors, and then you add localized topical estriol cream to bind whatever estrogen receptors are still functioning, you are hitting the VEGF pathway from two entirely different angles simultaneously.
We are basically creating an overwhelming biological mandate for the submucosal microvascular network to regenerate. Like you leave the tissue no choice but to rebuild.
You command the fibroblasts to upregulate endogenous collagen type I and 3, and importantly, it restores tensile strength without causing fibrotic scar tissue. The body heals correctly rather than just throwing down haphazard scar tissue.
Right. Now, as incredibly promising as VEGF synergy and angiogenesis sound, our sources from the Women's Health Clinic throw a very deliberate caution flag here. They advise clinicians to practice cautious biology.
Yeah, it's a vital reality check for any medical professional working in regenerative medicine.
It really is. Because it is so easy to get swept up in the medical buzzwords. We hear angiogenesis and we immediately picture, a barren, cracked desert instantly turning into a lush rainforest.
Right.
But the clinic notes that while VEGF signaling is biologically proven, clinicians cannot make guaranteed promises to a patient that their blood supply will perfectly return. What does a clinical failure actually look like? What's the limit of this biology?
Well, biology is not a controlled petri dish. Imagine a patient with grade 3 vaginal atrophy.
Okay.
This is a state of profound ischemia years of blood starvation, severe tissue erosion, and near total loss of the underlying cellular factory. Even if you deliver the pre-cut lumber in the blueprints, if the factory itself has completely burned to the ground, the body might not have enough living fibroblasts left to even respond to the signal.
That makes a lot of sense.
Yeah, we are facilitating and signaling for repair. We are not waving a magic wand that can undo decades of cellular death in every single patient.
I really appreciate that grounded reality. We are working with the body's existing capabilities, not just replacing them entirely. So keeping that very real biological caution in mind, how do these therapies actually perform in the real world, on real women?
The clinical data is really strong.
Yeah, we have a fascinating study here from obstetrics and gynecology reports to look at, and it focuses heavily on the non-hormonal side.
Right. This was a real-world study involving 54 postmenopausal women, all suffering from severe vaginal atrophy. The researchers actually utilized polynucleotide-based vaginal ovules, essentially a suppository,
Okay.
and they combined the PNs with hyaluronic acid for an extra boost of mechanical moisture and lactic acid to help aggressively drive that vaginal pH back down to the healthy acidic 4.0 to 4.5 range.
And to measure the actual results, the investigators used the Vaginal Health Index, or VHI. For you listening, this is a 5-point scale that clinicians use to assess 5 specific parameters: tissue elasticity, the volume of secretions, the pH level, mucosal integrity, meaning how easily the tissue bleeds or shows those painful petechiae, and overall moisture.
Out of a total possible score of 25, anything below 15 indicates clinical atrophy,
Right, and the baseline average for the 54 women in this study was a 2.3.
which is just. At 2.3 is profound suffering.
Yeah.
At that score, the mucosal integrity is basically non-existent. A woman at a 2.3 is likely experiencing pain just sitting down or walking. Intimacy is physically impossible without tearing the tissue. The pH is entirely out of balance, meaning chronic burning and likely recurring infections.
But the results after just 2 to 4 weeks of using a daily PN ovule were staggering. I mean, according to the data, vaginal hydration improved by 59.8%. Secretions improved by 52.7%.
Those are huge jumps.
But the numbers that stand out the most are the structural ones. Superficial petechia, that painful bleeding with light contact, improved by 51.6%, and deeper tissue elasticity improved by over 50%.
And those structural improvements, that's the proof of concept right there. When superficial bleeding decreases by over half and elasticity actually returns, it proves this isn't just surface lubrication. The tissue is literally regaining its mechanical stretch and its cellular integrity. The blood vessels are actually returning.
I do have a very practical follow-up question here, though.
Yeah.
If we know that polynucleotides degrade in the body via those native enzymes within a matter of hours, or maybe a few days, how on earth are these women seeing structural elasticity improvements weeks later?
It's a great question.
Like, does the injected DNA essentially teach the tissue to act young again? Or is this a treatment a woman has to use every single day for the rest of her life to maintain that 50% improvement?
This goes right back to your construction site analogy. The polynucleotides themselves do not stick around forever. They are rapidly consumed by the body. But they turn the cellular factory back on.
Oh, okay.
By providing that massive influx of nucleotides and stimulating the A2A receptors to stop the inflammation, they literally kickstart fibroblast proliferation and neocollagenesis.
So the factory just keeps running and producing its own collagen long after the initial shipment of salmon lumber is used up.
Precisely. The momentum continues. Now, it's not a permanent one-and-done cure for aging. For the injectable versions of PNs, clinical protocols usually require about 3 initial priming sessions spaced a few weeks apart.
To get the factory going.
Yeah, that gets the cellular machinery humming at full capacity. After that, a patient might only need a consolidation or maintenance session every 6 to 12 months. You're sustaining the tissue's own biological activity, rather than applying a daily temporary coating.
That is just a complete paradigm shift. We have moved from a mindset of just trying to survive the severe drought of estrogen loss to actively rebuilding the microvascular networks and the collagen scaffolding.
It's a totally different era of medicine.
It really is.
Yeah.
Whether you're navigating natural menopause or looking for safe, non-hormonal options after a brutal cancer battle, or if you're just fascinated by the sheer mechanics of cellular healing, the era of merely lubricating tissues is over. We are firmly in the era of cellular reprogramming.
If we connect this to the bigger picture, the ultimate goal of all of this, the entire reason we study VEGF and salvage pathways and microvascular density is about restoring homeostasis. It's about giving dignity and a high quality of life back to the patient. When you restore the underlying tissue, you restore comfort, you restore function, and you give a woman her confidence back.
Absolutely.
Yeah.
And I want to leave you with one final, somewhat provocative thought to mull over. Today we talked about how we can take purified salmon DNA, utilize the human body's natural salvage pathway, and literally command degraded, atrophied mucosal tissues to rebuild their own blood vessels and collagen.
Right.
If we can do that locally. What is the biological limit? Think about it. What happens when medical science starts applying these exact same DNA blueprints to heal major internal organs?
Oh.
What happens when we try to reverse age-related microvascular degradation inside the heart or the lungs or inside aging joints? If this is what cellular reprogramming looks like today, the future of anti-aging might just be swimming upstream. Until next time, keep diving deep.